Start by welcoming everybody to this March meeting of COIN. I'm delighted you're all here. We've got mostly people who know COIN very well, but I think there might be one or two new faces amongst you who are joining for the first time. James Kingsland, as many of you know, is leading on a series of projects around England, which have focused on providing a particular focus on developing projects to reduce health inequalities, and in particular, many of them working with their communities in the spirit of COIN, and many of them using community-orientated integrated practice. And it was really refreshing and exciting to hear of those projects that are working. So James sends his apologies for tonight, but I wanted to mention that in particular. But before we start with the new members, Vicky, I wonder if you could just speak, because I know you've only got a few minutes and you're over in Kenya at the moment. Last time you spoke, you were in Liverpool. Now you're in Kenya. Could you just say hi and just introduce yourself, please?
Yes, Vicky Doyle. I'm a co-director of Capacity Development International. Do a lot of work on looking at community-led models of trying to improve quality and health equity. When I spoke last month, I was talking about the work I've been doing in Liverpool, which has been influenced by the work in Kenya. So I'm now out in Kenya training, working with about 16 the community innovation teams, again, tackling the interface between community health and primary care. And so the work we've done in Kenya actually has inspired a lot of the work we've done in Liverpool. And in fact, we got this exchange happening between the two countries as well, between Liverpool and the Homa Bay later this year. So quite exciting stuff, actually.
Thank you, Linda. Lovely to be here. Margaret Hannah, Director of Health Programmes at International Futures Forum. We're very much a small charity based in Scotland, but with a worldwide community of people that we support to make a difference in the face of all that stands in the way of making a difference. We deal with complex, messy, seemingly intractable challenges, and we bring a lot of fresh thinking, ways of being, knowing and doing to that task.
My name is Sharon Kumalo. I'm here on my organization, Central London Community Healthcare Trust, where I work there as a community matron for long-term conditions management, and I have a special interest in advanced care planning. And out of work, I am also involved with a charity in Zimbabwe for a hospital. So we're trying to revive the hospital.
Thanks very much. You may not have heard of the British Holistic Medical Association, but we've been going 40 years. 1984 was a different world. And the Reagan landslide, the first Apple Mac computer, Queen were in the charts, Greenham Common, Band-Aid. I mean, and 40 years on, it's such a different world. And our founding principles really were that the idea of enabling broader diagnosis by psychosocial diagnosis was probably the strongest one, but then to inform and empower and support clients and communities in order to make some sense of the diagnosis and do anything about it. And that would mean assessing wider interventions and enhancing practitioners' self-care knowledge and skills and own well-being, and then to research in ways that reflect real practice. So that came out of an inquiry we did with Peter Reason. And then 20 years later, I founded the Journal for Holistic Health. And really, by the time we founded Holistic Health, I think we were imagining in the early 2000s that a lot of the problems of extreme biomedicine were fading away. And something happened in the subsequent 20 years, I think you'll agree, whereby the omni crisis, the planetary omni crisis, the cultural crisis, the health crisis, all these colliding crises seem to have got so much worse. And yet the industrialization of healthcare is clearly not the answer. And so the journal, particularly recently, has started to focus on humanizing healthcare, reimagining healthcare. What would medicine as if people matter look like? And so particular streams we've been working on lately are the humanities, self-care, the problem of burnout, the problem of declining morale in healthcare, the cost crisis, the care crisis, the commitment crisis, and all of these things. We've been trying to find various voices to come together, and then most recently talking to different organizations, some of whom are here tonight, and particularly lately to Paul. It seems to us that there needs to be a united front and a united voice, and maybe a radical journal that can express these different interlinked streams in the complexity of health and the health crisis. And so that's what's brought us together, and the practical and strategic benefits of what I understand as the COIP perspective are particularly valuable, because it's all very well to talk about holism in healthcare and holism as a way of thinking and a paradigm shift, but how do we enact it? And that's the problem, and I don't think we've got an awful long time to solve it, or at least to begin to get the ball rolling so that things begin to find their way into the mainstream. So that's the background of JHH, and the idea, as I think Paul will tell us, is to have for the next few issues at least a section dedicated to these perspectives, the COIN perspectives, the COIP perspectives, and probably to have some sort of joint conference for the various collaborating organisations in a year or so ahead.
To have you here, Nigel, and thank you very much for putting us into your tight schedule, and we look forward to hearing what you have to say.
Well, great. Thank you very much. A real pleasure to join you and so many people. Briefly, my background, about 10 years in community work, most of that in Liverpool, actually, Vicky, but in the 1970s, when I'm sure you weren't working in Liverpool at the time. 20 years almost to the day in the NHS, ran the Oxford Teaching Hospitals. Best job I had in some ways, David, was working with David Colintomi and friends running the NHS in London, where I had the best team that I ever worked with, David, I reckon. I don't know if you agree with me. And also met Hazel at that time. And then I ended up running the NHS and being head of the Department of Health as well while I was at it. But the last 18 years, I've actually been working in Africa, mostly voluntarily, with the whole in African countries, in about 10 different countries. A lot of it's about partnerships between UK organisations and African organisations. And I have to say, I've learned an enormous amount. I've changed my perception on health fundamentally, coming from, in a way, an acute background, although I'm not clinical, so I don't have a professional background, but understanding how you have to think about health and healthcare in really quite different ways. Wrote a book about it called Turning the World Upside Down, which was actually about, and again, Vicky, you may recognise this, about what we can learn from people who don't have our resources, but also don't have our baggage and our vested interests, and quite often we'll be doing stuff that actually we can learn from, even though they've got a tougher job than we have. So that's where I'm coming from overall. These days, I'm an independent member of the House of Lords as well. And actually, it just occurred to me when David was speaking, that Dave, perhaps is it Dave Peters, that I ought to just say I also co-chair something called the All-Party Parliamentary Group on Beyond Pills, which you can imagine what that's about. And therefore, if you're looking for allies and so on, maybe there's a conversation we should have at some point. In Africa, I got very interested, or subsequently have got very interested in creating health. Prevention and protection and health services, great, but also the creation of health. And my definition of that is terribly simple: creating the conditions for people to be healthy and helping them to be so. But actually, if you create the conditions, you often don't need to actually help them. And that's something that's done not just by health workers, of course. You know, all kinds of people do that, starting with one's parents, we hope. If you had a decent teacher or whoever else in life may have helped you with health creation. But underneath all of that, what I've really, and this is what the reason I wrote the paper, well, I was asked to write the paper is the reason I really wrote it, because Paul asked me to write it. He asked me to write about policies. Policies for compassionate communities is where we started, Paul, wasn't it? And underneath all the policies, the biggest single area for reform, in my view, at the moment, is about professional education. The professional education of health and care workers. How you, and I say this with great modesty because I'm not one. I mean, I've been a health manager, but I'm not a clinician. I expect almost everyone on this Zoom is a clinician in some form or other. But actually, how you see the world is how we'll see the world. You know, if you see it as about doctors and hospitals and, you know, waiting lists and targets and all kinds of stuff, then we'll see it like that too. If that's how you see it, of course, that's how you'll behave. And actually, the biggest changes are probably going to come from within your professions. And I'm not talking about medicine, I'm talking about the professions, including social work, changing the way they see the world. I think that's the great revolution that will underpin the things that I think people, from what I gather, care about here. In the article I've written, I discuss 3 national policies, great transformational potential, visionary policies. Sure Start in England really had a fantastic stuff. Then Scotland, 10 years, that was 1999 that started. 2009, the Scottish government set up the Early Years Initiative to make Scotland the best place in the world to live. And some of you will know Sir Harry Burns, who was the CMO, I think at the time, but anyway, a real leader on that and a great visionary person. And the third policy I discuss is New Zealand's, and we haven't got any Kiwis on the call, have we, I don't think, but New Zealand's wellbeing budget. So great vision, which was focused very much on mental health and well-being, as you may be aware. And all of them, when you look at them, they've all achieved a great deal, but they've all run into trouble. Sure Start ran into trouble with austerity. And, you know, it's meant one of the biggest casualties of austerity. Early Years, if you talk to Harry now, as I did a couple of years ago about it, he'll tell you, well, it was so successful that they decided to extend it to everyone under 18 and to introduce a whole range of targets. And he said it became all about targets and managerialism and lost the community and relationship sort of stuff. And then the New Zealand wellbeing budget, well, the next Prime Minister introduced a budget, and if I say that he described his budget as a practical budget, you will understand the great change that was in the atmosphere and so on. And all of those fell apart because if you're going to have a decent policy that you're going to make work, you need 2 things which you very often don't have, which is the people who have to implement it absolutely bought into it. And I mean bought into it mindset-wise. And that is difficult because particularly if the mindset is different from the traditional one. And so you need them to have the right skills to implement it, which again, if those skills are not the traditional, then you're in trouble in however you want to describe trouble. And all of those policies, those big policies I talked about, you could see how they ran into those sort of troubles. And when people run into trouble, financial, political, whatever it is, they revert to type and they revert to old methods and old methods of behavior. And so we got people reverting to the things they knew and the things they knew worked. Now, let me be clear. I'm a great fan, and I think I say in the article, I'm in awe of the scientific development and the current professional skills of professionals. You know, I mean, that's fantastically important. None of this undermines that science. This is, if that's the left hand, this is the right hand. You know, these 2 things go together, don't they? Absolutely. So, and then my article continues referencing Hazel, who's blushing over there, I hope, and the work that she and colleagues did in Falmouth in the end of the last century, actually, where she and a few colleagues from different agencies, together with some local people, got together, pooled their mindset, is how I sort of think it. Worked together and created some really interesting results that show you some technical results, but also change the atmosphere and change the way things working. And it was about relationships, wasn't it? And then the final bit of my article really just says that in 2020, I published a book with a wonderful title, which is not mine, Health is Made at Home, Hospitals Are for Repairs, which was coined by a great friend of mine, Francis Omazwa, when he was running the health system in Uganda, roughly the same time as I was running the English one. And it's about creating health. And I visited 60 organizations around the country, including Hazel's, and talked about them and learned some really interesting lessons from people who start off with a vision and a purpose, not with a plan. The NHS and bureaucracies start with a plan, don't they? But they were, you've got vision and a purpose, you can switch the plan if it doesn't work. They start with relationships, not with systems. You need systems and processes, but actually start with relationships and then build the systems later. Don't start with systems. Whole lot of learning from that. So all of that amalgamates into essentially my last paragraph in a relatively short article, which is really arguing that fundamentally, if we're going to see the changes that I think a lot of people want to see, and I think there's a lot of people who want to see the movement that you're talking about here come into globally, not just in the UK. Actually, the people who are going to make the change are the health professionals, health and care professionals. You can't expect the politicians to get it if your profession doesn't get it. There's a serious shift there that's in hand. So that's my contribution. Thank you.
I wanted to refer to the Healthcare Act of 2022, which I heard delivered by a man by the name of Kunal Shah, who's the Associate Director for Science and Policy Research at NICE. Why do I raise that in this context? Because the British government now charges the NHS to pay attention to planetary health. This links into the net zero commitment policies that they established. But I mean, I wonder, this is a huge policy shift. If the health professions, which I absolutely agree with you, are absolutely key to addressing what my paper is about, the climate crisis, now have to have a system that says we need to pay attention to broader aspects of health rather than just clinical, and even for that, rather than just public health.
I mean, my view of it is very simple. I say this in the paper, is that the health of the individual is intimately connected with the health of the community and intimately connected with the health of wider society and intimately connected with the health of the planet. And I think a lot of people are coming from that perspective. But that's the perspective we need, because you've got to join these things up. It's good to hear that the British government is pushing in that direction. I don't know how far they're going to push before they're pushed out. But let us see, and let us hope any future government of any particular description will see health in those very wide terms.
Thank you, Linda. My paper is really a continuation of a presentation I made about 2 meetings ago before about general practice. My premise of the paper is that the NHS significantly needs transforming, not only in its bioclinical sense, because our health outcomes are some of the worst in Western Europe, but separately to that, and that's health-related ones, not necessarily the health of the population, it's healthcare-related activity that we don't do well in. But also, it pays scant regard to the health of the public. It focuses almost entirely on healthcare, and entirely almost on hospital care is what is the downside. So my paper is, I'm a GP by background, but in my life I also spent some years as a local councillor, working up the government. That's how I met Nigel. And so I've had a couple of academic attachments related to the NHS. So my premise is that if the health service needs reforming, I think the reform has got to come from, in a medical sense or NHS sense, from the bottom up, and it's got to be from primary and community services. And we need to shift the whole emphasis for the health service to that aspect of delivery. So my experience over many years of various, I call it a journey of discovery, which many of my colleagues in general practice and in community services have shared with me, is how do we build from where we are now? One of the unique building blocks for general practice is that it's unlike any other healthcare system I can ascertain. We have a population responsibility at the smallest unit, which is the general practice. That's pretty unknown, I think, generally. We don't always discharge that responsibility in general practice, but at least it gives us an opportunity to develop. So that's where I start from, and I map in my paper the various experiences I've had to get where we are now. So number one, about 2009, when I was working at the Department of Health, I originated a concept called the primary care home. So this was a population-based, just a home, but it included all people who work in community services. That is all the professionals, pharmacy, community nursing, and in my paper, also social care and any hospital staff that work in community settings. And we had a population responsibility and had to work together to do better care and help people's health. So I set up also a triple aim of how do we have to expand primary and community services and look at the quality. We can help to reshape care by better primary and community services, reshape hospital care, but also with a population responsibility, work with others on improving the health of our communities. And that was the sort of triple aim. We developed a program, an organization called the Primary NAPC, National Primary Association of General Practice, developed a program to deliver on my primary care home. And we finished up from 15 in 1915 to about 200 odd sites by 2019, doing fantastic stuff, both in clinical work as well as in health inequalities. And it was so well organized and popular with lots of people that the government adopted it as a policy, and that's where primary care networks came from. So that's my story of the journey. But there are certain key issues, I think, that I think might be of use that is not in the NHS standard management or leadership zone, really. So number one, I've talked about the home, but Nigel has picked this up, and as he said, he's had this change of direction over the last 20 years from when I knew him as Chief Exec of the Health Service. And that number one issue is that we need to build on relationships rather than the obsession with contracts. That contracts should be at the very least a fail-safe if things go wrong, but not define the culture. I'm keen on localness, and that's why my general practice background attracted me to be involved in local communities. And it's where you often get the best opportunity to also tackle complexity and all the other difficult areas, paradoxes and wicked issues. So we need localness, and that's the heritage of general practice. It's the heritage of community service, the heritage of community pharmacy, of being part of an anchor organization for local communities. But if we wanted to be effective, we had to be both little and big, local as well as strategic. And that is superficially a paradox. And some of my work has been involved in that area. One, the primary care home can be small or as big as it wants. The thinking can apply to local health units, but also combined together in the current population recommended of 50,000 population, you can have much more influence beyond the local community, and especially in the health service. And so we can then therefore extend the community population responsibility and maintain local personal care, which we must never use. It also strikes me that this is a particular home, which I hadn't thought of till I was involved with COIP, of involving the community practically in that co-production that Paul talks about and we'll talk about soon. So I think this seems to be where we need to be. And if you shape it that way from the people, then I think we have a real chance of beginning to transform the healthcare system, the NHS as it is. I'll make a point about social care because they are sometimes separate because they are run by local authorities. But if you have relationships, as we developed, you can still work with people across boundaries, across organizations, if there's a willingness, but often you need to have a base to have a common base. And therefore, I think we need to be much more integral. Primary care networks, as they were set up, of course, had two problems. One, it was built on our good work, but as soon as it becomes national policy, then there's a certain dead hand about that, and that is an issue. And the other, it tended to localize itself to only general practice and community nursing services, which I thought was disappointing because social services are very much part of that local caring ecosystem. So I think that's where I'm saying we should go. And the primary care network, because it isn't a statutory body, it is a population of 50,000, which is about the population built up from GP practice populations. And it has multiple functions. It should not be and never should be hierarchical, even though the health service pressure might try to make it so. But it's about different organisations having different purposes and working constructively together. I think this is a message for NHS management, a more participatory model of management rather than the hierarchical top-down that we have been used to. So that's really where I'm coming from. How can we build? And some of my experiences, and of others, have had formative experience for us, because these are the practical ways that we've built up a case rather than just having a dream and saying that's where it should be. I think it's realizable. There are two countries which probably have gone that way already. One is, and I know at the moment they're quite obviously a pariah state, but Israel, back in 1995, developed a primary care, certain focus of their healthcare system. And just recently, the Republic of Ireland, as they prefer to be called, have done similar. I went to speak at a conference there a few months ago. So if they can do it, why on earth, with our well-developed general practice as a building block, can't we? And that is about political leadership and all the others. In my, from 1966, when I qualified as a doctor before I became a GP, there have only been three significant leaders, one political and two chief exec, two political and one chief exec, who had taken any real interest in developing primary care in the way that I've described as being strategically important. So we've got a lot to do, but as long as we're working together in our local level to show we have the ability and the influence, and when you look at what Hazel has done down in Cornwall, working in that area, we have the potential to really transform the health service. So that's the gist of my paper, Linda.
Thank you. Thank you. I wondered where you felt one of the things is the relationship between your view of primary care and the view that Nigel expressed about the education of the health professionals of the future.
It's part of our same movement to reshape how we think and act. So Nigel's work and how he's now discovered through his work in Africa about how it's about relationships rather than processes, and about it which has been my theme for some years too. So, and Nigel, that any care professional can be a leader, but will need to have the right mindset is absolutely right. Because even if we don't get senior leadership to back us initially, if you can build up a network of communities working in this way, then we have much more chance of making it spread.
It's not a question, but it's just to say thank you, David, for your perspective. I completely agree. I suppose I would do as an ex-GP, but if you know Sam Everything's work at Bromley by Bow,
yes,
been really pushing hard into the GP apprenticeship scheme, and beyond that, the idea of a primary care-based medical education, where people start right from the beginning with very diverse aspects to live and work in the community to become primary care physicians, because that's the difficult job in healthcare, not being a partialist but being the generalist. And they're quite a long way advanced in their plans, and I knowing Sam, I think it'll come off.
Yeah.
Well, I didn't know that last bit, David, about the education. So that's I suppose another strength to our bow, really, that if we can do it in primary care and community services with all our colleagues, and including us in COIP with our community of citizens, then we were bound to get more notice as a credible force for change, really.
The thing that strikes me, David, is that this is terribly obvious when you know it.
Yes.
The trouble is that people tend to know it when they're sort of retirement age or when they've battled against the world and whatever. And I think that what COIP should do is to just make this sound terribly normal and ordinary and everyday. We should teach it to school children and let the doctors catch up.
Well, I agree about it being obvious, but you see, I still speak to quite a few GPs who are quite happy to have more impersonal care rather than cast aside our heritage. I mean, there is, as Nigel says, a lot of work to be done.
You've got to give the community the opportunity to participate, haven't you? You've got to
Yes.
work with them and enable, it's about, as you say, bottom up, not top down, very importantly.
And our cultures, sorry if I just butt in, our cultures of the power authority of our clinicians, coupled with now the power authority that the NHS leaders began to get from the changes.
Into the chat, just a couple of comments, David. One about Christchurch in New Zealand, which has got a very good integrated model of primary care, worked very successfully in response to the earthquake there. And they too do the workforce development side of it in an integrated way. And the other one was in Scotland. Our graduate entry medical course has got a very strong focus on general practice and training doctors to be GPs in rural areas as well. So there is a growing recognition that basing your medical training in primary care is the right approach.
I think just on the New Zealand issue, which I have some experience with, I'm just worried with the present change, radical change in political leadership. We might undo a lot of the work that's been done. Because for a long time in the Antipodes, the GPs didn't have a population responsibility, and New Zealand then developed a system where they did, and there were, and in fact, even Australia have developed one. There is a message here that you have to have personal care and population responsibility, and it shouldn't just be left to public health people. It should be all of us are public health people. But I'm worried about New Zealand at the moment, having a wonderful leader to now gone quite a populist group of people is quite a disappointing shift.
Yeah, indeed.
We do have quite a good psychosocial model, and in Bromley Above, I'm sure you all know about it. But I'm the lead for complex integrated care at our practice, and definitely agree with what you said about the relationships. So, and it's not just about the medical relationships, it's about the nurses, it's about the carers, it's about picking up the phone and talking to the social worker. And that comes by making relationships and having relationships with them and keeping them going. I mean, the model we run is we have an MDT once a month, but I know that I can pick up the phone or I can email someone if I have concerns about a patient, and vice versa. They know how to contact me. But I find lately that the demand is really high, and we have a new category of healthcare workers. They're not medically trained, but we call them care coordinators. And they have taken over a lot of the work that I used to do. And I've noticed it's great. I don't have to do so much because they've done most of the introduction and finding out about their social care, and are they having any falls, and do they need any help? Are they lonely? All these sort of wider determinants of health. But I find that then it takes me longer to get to know the patient, whereas I used to do all of that myself. So yeah, I think there's great stuff going on. We're working collaboratively, but the demands are really high at the moment as well. So yeah, thank you very much.
Just to note, I suppose, that some of the themes that both David and Nigel have said thus far, you and I, as in Linda and I, are working on from the institutional angle on our paper. We might hear a bit about that in a few minutes' time. But can I just applaud, David, your use of language in just one very small area where you suggested that relationships should take priority over contracts.
Yeah.
And that I mean, that overweening process that we've had to endure since 1990, which was writ very large in the 2012 NHS and Social Care Act, thankfully has, for the most part, gone now, but some entrails of it remain. Was that what you were getting at there? The dreadful purchaser-provider split and all that went with it?
Yes, it's interesting, and it might be something. When it was the Conservatives in Thatcher's time introduced the market reforms, and I became one of those GP fund holders, and we were meant to be mini purchasers, which of course was complete nonsense. What we liked was having a budget and do some of the development work that we did. That's just a little political point, really. But that's where it became stark. And the health service has always had a power authority culture, often read by doctors and nurses in the old days, and then the management power structure. Then there was that awful thing in the 1980s called the New Public Management, which I think put us all on an even worse path, where it was ostensibly about the customer, but it was all about contracts and targets and all that dreadful stuff, which is what we've inherited ever since, and we haven't really shed that. And there's no way. And if you ever talk about commissioning, it's not about enabling their communities and their staff. It's about these damn contracts, which are meaningless, and people fiddle them and all the other things. And it is really, I mean, the health service, forget the financial thing, the health service culture now is at a state where it's really hard to see progressive ideas flourishing. That's why we need strength in numbers.
I'm an academic dietitian, so basically work or do mainly sort of postgrad health courses. I'm based at Imperial College and Royal Holloway at the moment, and I'm more and more of my research has moved towards public health, and just listening to the things that you were all talking about today has been really interesting and inspiring.
Reassuring, because I think, yes, obviously I work in an art context, but a lot of the work we do at Open Eye Gallery is around, a lot of the commissions we get invited to do is I guess the alternative to medical thinking around kind of expression of voice, well-being, community growth, and quite a lot of the projects we do have been in partnership with NHS. Or we're working with people who have very specific conditions, and so we've done projects with people that live with early onset dementia, and really for them it's about using the photography as a voice to raise awareness about actually how they maintain the lives that they do have, the carers and relationships they do have, and breaking down stigmas around that. So sometimes it's about accepting what conditions they do have, but raising greater awareness around the storytelling of that and creating a bit of a sense of agency and control over that condition through photography. So it's these alternative ways of thinking, but it's been really interesting to listen to everybody, because I think Paul mentioned it. To me, a lot of what everyone's saying is common sense. Like, why would you not do things collaboratively? Why would you not do things that are locally rooted? And it is almost a case of, to me, it makes perfect sense, and it almost baffles me that at policy and government level it's not, or not. It baffles me. But I'm really happy that this group are kind of coming together to acknowledge that and challenge that and think about, okay, well, how do we do that? Maybe that's from the ground up. So yes,
first, I'm a geriatric neurologist and primary care wannabe, influenced by my friends Kurt and Paul. Also English, Scottish, but work in Canada, hence the conference with the robot. And I've been working on caregiving robots for about 20 years. And in the last paper I wrote, I said, maybe if we can teach robots how to be empathetic, we can teach health professionals how to be empathetic.
More difficult.
Now, Paul asked me, thank you, Gina. Paul asked me to write a paper on the climate crisis. But like Dave Peters and Nigel Crisp, I didn't want to focus just on the climate crisis. So I focused on what I call the meta crisis. And I will say a couple things. One is I love that comment about relationship and not contracts, because we've got to fight neoliberalism. I mean, if we're professionals, it's relationships, it's not contracts. And also it's relationships with nature, not just with each other. And in fact, folks, the determining figure in all of what we're talking about today is going to be Mother Nature. We are facing, and I'm getting into my paper now, we are facing a time where the Gulf Stream may stop, or take your pick of the discontinuous events that are going to contribute to the greater challenges, which are beyond the scope many of us can even think about. Now, to my paper, I start with this idea that the future is not what it used to be. We've had this great acceleration. I was born in 1949, as I said. There were about 2.5 billion people on the planet, and there are now close to 8. And we've got this very controversial concept of the Anthropocene, which talks all about the human relationships with nature, where the geologists who've been working on it for decades now decided we're not in a new geological epoch. We're talking about the sixth extinction, where we have created an environment in which many species are going extinct before we even know exist. And I think we are headed towards a great deceleration. That's to say, we are going to face challenges where we have to organize our healthcare systems around smaller populations and probably more locally. I just had major surgery at the Cleveland Clinic, cardiovascular surgery. And right after I got out of the ICU, I attended a program on the ecological impact of ICUs. 180 plastic gloves used in an average day. And based on my experience, I would say that's about right. This is not sustainable. We cannot think of healthcare as the high tech. And of course, the Americans, of which I don't identify strongly with, are absolutely the worst at this. So we've got this collapse of a larger picture, a meta crisis. And healthcare is an absolutely critical lens, because it's increasingly going to be people's health and community health, which will bring the crisis to people's attention, whether it's the things we've talked about already, air pollution, heat. I mean, take your pick. So the question is, how do health professionals behave in a world that is changing so dramatically, and use health as a lens to change society, not to think of society as the dominating force. Of course, Margaret Thatcher didn't believe in society, but whatever you call it, the question is, how do we as healthcare professionals create the kind of transitions that we want to see in this larger society?
And also the emphasis he placed on, we need to learn what is to be human, what is to be a learning human. I kept that because it feels to me that is what I have been passionate and what I have been working on from a very, very different perspective, obviously, working with dance with a particular frame and principles of practice within dance and very, very diverse learning environments, age groups, ability groups, and so on. And in many respects, what I have been noticing all along, not just as a practitioner, a somatic informed, as we call it, somatically informed dance practitioner, but also as a carer of my late dad, as a citizen, as a patient, all along this process, and as a person knowing the body a lot, sort of deeply, is noticing what is to be an embodied being and having an experience of the body, whether that is an experience of pain or an experience of illness or experience of joy, experience of community, and how does that alter the sense of existence, the value of existence, and so on, and therefore the sense of self, and the sense of health, and something that stayed with me a long time ago, when I was doing my PhD we were sort of talking about practice-based research and what that means, and the importance and the impact of our work. And there was this discussion between two academics, a doctor, academic, and also an artist. And the doctor said, you know what, actually, it's interesting. We do research to learn how sort of how to sustain life, but you do research on how to make life valuable.
Three wonderful, that Nigel Crisp, those three wonderful initiatives, if you like, that failed. What was it that caused the failing? And it's the economic system that, in effect, and one can't ignore that. We're in this, wider ecosystem of neoliberal economics, which has a very difficult effect. So, and I'm just thinking also of Don Berwick era too, which was stuck in with the managerialism, the new public management, which is still with us. And he talks about era 3, the moral era, where which is much more the direction we want to go. But it's difficult, isn't it? And I mentioned I just mentioned a thing about what's happening where I'm a patient and was a GP. The ICB is imposing a kind of triage hub system where you ring up, you're not going to see the GP, you're going to be put into some hub where you will have perhaps somebody who's not actually medical triaging you and deciding who and what you see and what happens to you, which means more fragmentation and less continuity, which is, I would have thought, all the evidence shows that we want to go in the opposite direction. So I'm just being a bit the devil's advocate and saying that bottom up isn't enough. That top down can have a crushing effect on these wonderful things that are going on that are going on at the bottom up. So
one thing I wanted to say, picking up what I've heard already, is that actually lots of people do want to do the right thing. My experience of developing primary care is that people really, 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 really will do it if they know how to and if they're supported. And actually a lot of people just don't know how. And one thing is the world seems to be imbued with this idea of linear thinking, that everything has to be compartmentalized and cause and effect and in straight lines or whatever, and without realizing actually that's not how the world works, and it's not the most helpful way to think. So I want to introduce you to Bridget and Maria and her 10-year-old daughter Maria. It's not their real names, but I'm giving them those names today because it strikes me that this is what it's all about. This is a photograph I took 2 days ago, Sunday afternoon, about 5 o'clock in our street, of two lovely people who were on a journey. And the photograph has caught a snapshot of their story in evolution, their life journey. And I was thinking, well, what does health mean in this context? These are two people who are travelers in life. 200 years ago, Kierkegaard said most organizational theorists, as well as most philosophers, mistake the certainty of structure seen in hindsight with the emergent order that frames living forward. Neither groups of scholars has come to grips with the fact that their conceptual understandings trail life and are of a different character than is living forward, and it's still completely true. Those two are saying goodbye with gratitude for what they've learned in their past, and they're going into an uncertain future. And yet medicine and so many people and politicians have adopted the idea that the only thing that matters is the picture, the moment there, the instant. And it's just not it's the wrong kind of science. This is a laboratory kind of science of looking through a pinhole camera to see one thing of something that's very complex. Now, a bigger truth about those two lovely individuals is that they are going to Ukraine. They are Ukrainians, and what am I calling them? Sorry, Bridget, the mother. Her mother was due to have an operation tomorrow in a Ukrainian hospital, so they are going there together to help her in her post-op stuff. Now, probably their future isn't going to be quite like that, because on Saturday night, the bombs rained down from Russia and it took out all the electrics of their town. And indeed, their mother Claire's front door's been blown off and there's no windows left in the house because they all went with it. So probably their tomorrow or today, wherever they are now, I don't know, is different from what they expected. Now let's go through this biopsychosocial, and I like to add spiritual as well. This is one road, this is about a few yards ahead of them there. Now, if Bridget, one of them breaks their leg, they won't get any further. Psycho, if Bridget forgets where she's going or loses the nerve of what she's doing, she won't get any further. Social, if she isn't able to be helped through the 3 trains she's got to get just to get to Stansted, let alone through Poland with its train strikes and then being picked up at the border to be travelled somewhere else, without those kind of social connections and support, she won't be able to do that either. And then spiritual, I'm not quite sure how to describe that, but something about the sense of purpose and mission and vision and connectedness and trust and versatility and ability to just feel your way through an uncertain future. Without any of those things, they aren't going to get beyond the street ahead. So I want us to remind ourselves that what we're trying to do as health creators are helping people to travel hopefully. Now, it's when it comes from that's the practitioner's point of view. When it comes to researching, we have to remember that this laboratory approach to just looking for facts is tied up with a well-known philosophy of science called positivism. It's laboratory science, and we need this science. Front cover of one of my books, painted by my 22-year-old son. He was a teenager then. If you look for a machine or a robot, that's what you're going to see. If you look for something more complex and dynamic and relational, that's what you're going to see. And I like this quote by Werner Heisenberg on the right-hand side, or my right-hand side anyway. What we observe is not nature itself, by nature exposed to our method of questioning. So if we can be clearer at a very grassroots level, but throughout society, about the combination of things that we want to look at, not imagining that they are hierarchical, but they are complementary and needed together, we will end up in a much better place. And we can do that now by gathering data in case studies that primary care networks can provide us to show in hard economic terms how relationship development and community development and trust and so on is economically beneficial, as well as providing you with other things as well. And I want to draw the Julian Tudor Hart's quote as well in his book, the new GP, I think, something like that, new kind of doctor. The misrepresentation of medical science as the solid, simple Newtonian certainty of engineering has misled not only the public, but the profession itself. And I think that's very profound. And general practice particularly, but all health workers and probably all society and probably all of medicine and medical school and schools need to understand that the robotic engineering image of the world is very useful, but it is only one. And it needs to be seen in harmony with other things. And as like Paquita said, you need top down and you need bottom up. And they need to talk to each other. We need horizontal and we need vertical integration. The trouble is these are unfamiliar terms, and they're not widely thought and taught. So we need to change that. These two authors, Egon Gruber and Ivona Lincoln, I think are essential thinkers in this territory. Egon has died. Ivona is now still emeritus professor in a Texan university. They developed naturalistic inquiry, which requires the research to see facts in the context of see facts in context. And Egon created this great book called The Paradigm Dialogue, in which he described the 3 paradigms of positivism, critical theory, and constructivism, each of which makes different assumptions about the world that are complementary. So naturalistic inquiry, positivism, which will see micro particles and facts. Critical theory that sees interconnected facts. And constructivism that imagines that everything is constantly changing in response to changes in everything else, that idea of incremental transformation, are generated very much by their thinking and their writing. And I think that this is a very big part of the future if we're to get anywhere with this. And they've wrapped that up in the idea of fourth generation evaluation. And this book, which, by the way, if you've got loads of money, is £50 on the Amazon and $95 in America, but you can get it a lot cheaper secondhand. Describes how you do it. And essentially you do it the same way that learning organizations do it. You get people together to stand back and look at a range of views, go away to do the small things you want and you can and you've promised to improve things, come back again and go away again and come back again and go away, and you produce cycles of collaborative learning and coordinated change. It strikes me that that works wherever you do it. So this is the image that I want to put on the table here. On the left-hand side is an individual who's overwhelmed by life and stuff, and they have, he has, she has, they have the opportunity to go under an umbrella periodically for a shortish space of time to meet with other people and have new ideas, have their own ideas challenged, and then go away and do those things and come back and go away and do those things. And that happens not just in one place, but everywhere. Now, this can be a general practice, it can be a primary care network, it can be the carer's home, it can be all over the place, but that can be the image that I would like to propose we move forward. And just one tiny little last thought here is that you'll see on the bottom left-hand side that closed locked box, which contains the things you dare not speak about. Because there are some things that we do not feel are legitimate to talk about. And underneath the umbrella, with enough trust and time, it's possible to open those boxes. So we've got 4 papers coming up. David's vision for 21st century health and social care. What is community-oriented integrated care? We've been both talking about. Holistic evaluation, which is what I've just been talking about. And Nigel's policy for health. Summer, we'll have 4 more. Autumn, 4 more. Spring, 4 more. We want each of those authors, please, to be able to continue the conversation. This is now going to model the sense of us being a community of inquirers, of friends, a network of people who want to make community-oriented integrated practice a reality. Bridget and Maria.
I've absolutely loved catching up with some of you. I'm a member of the 49ers too, Peter, and I believe that probably the 2 Davids are. And with great respect, isn't it wonderful to be us old dinosaurs and to at the moment we're getting, I was talking to Michael Dixon about this the other day, we're being upcycled, aren't we? Because suddenly the things we've been banging on about for 30 years, saying exactly the same things, are suddenly okay. You know, I'm looking at that box. Thank you, Paul. That was very powerful. And I was listening to everybody that's spoken has resonated with me tonight. Particularly, was it Liz who said it's a no-brainer? Some of the things, I mean, what the success I've had. I know I'm known for the Falmouth work, but I'm a nurse by background, and what I do is about wellness. Why on earth do we not work collaboratively with the police, with education, all these people that create health, housing, local government? That's what I've been doing for 30 years. I heard, and I still hear it now, people say involve the community. You must have the community. It must be bottom up. Enable them. Sorry, that is not enough. They have to lead it. They have to be the lead agency. They're the lead agency, but they work as equals with everybody else. And these relationships, it's who you bring together, how you do it, particularly how you do it. There's a lot of leadership involved in it that's quiet.
Right. Okay. Thank you. I was very struck by the comments that I think it was made in Nigel's session that if they can do it, why can't we? They being the State of Israel and the Republic of Ireland, I think. And I wondered if anyone had any ideas of how you'd answer that question.
I was given the impossible task of trying to summarize everything I think I had heard. The politics was a huge part of it, neoliberalism and the movement towards populism. came through the idea of Christchurch, Ireland, and Israel, and as an American learning about the NHS, is that in all those examples there were pressures on the community. In Christchurch, after the earthquake, is when collaboration really started to develop, and the same might be true of Israel and Ireland. That if we consider the environmental pressures that we are all under as humans on this earth, we may be looking broader to a sense of the pressures that a healthcare system might be able to thrive under, rather than relationships or contracts. So I heard 3, 4, 5 people refer to the idea of relationships, not contracts, really hitting home for them, ringing true, making sense, and within that context of political pressures, system pressures, and environmental context pressures. How do we build relationships in a way going forward if the effort to create new management systems and contracts hasn't actually solved our healthcare problems? It may have actually broken our ability to relate to each other. We have a tall task ahead of us. And so what I also heard repeated as a theme was actually in the people commenting that there are a lot of retired GPs or people towards the end of their careers who are retiring, who are also patients and also carers, which is also true of myself, that we are at all times, all of these things, and a system that breaks into constituent parts forgets that in any day we might be playing one role or the other. And if we are going to see ourselves as health creators on a daily basis, whether those of us who are teaching continue to teach, those of us who are elders who are continuing to share, those of us who are young who are trying to learn from others, and all the way we feed back, that collaborative co-development is not a new idea. It keeps coming again and again. I just am struck by these wonderful ideas, and all of you many of whom I've known for many years, bringing the same ideas up with hopefulness that we might be able to do it even after decades of being broken in so many ways. I'm teaching right now registered nurses in the US, and I'm teaching a course called Policy and Politics in Healthcare. And I'm teaching a course called Leadership and Management in Healthcare. And in a very American way, we have these two ideas. And nowhere in there does it say, think about relationship. I still have to teach these future healthcare providers a process for learning how to do something and then also build relationship. And I think if we can give anything to the future in our literature, in our journal articles, in our experience, it's sharing those things back, which I've learned from my children doing improvisational comedy. It's the yes and. We need process. We need new process. We need new ideas. I heard that from the speakers. But we also need a way to continue to understand the context. We need to understand how to build relationship. We can't have no process. We need both process and relationship. And I really look forward to seeing these articles and the way that we can do that through our politics. We can do that through our training. We can do that through our art. We can do that through our experience of healthcare from inside as patients and carers. And we have a lot of work to do to rebuild a new vision of a future where all of that works.
I just want to say that in the chat, everybody's gone out saying, what a great evening. Thanks, everyone. Sorry, we've got to leave. It's been really exciting. Positive comments all around. So well done, everybody, for everything you've put into this session today. It's been outstanding. Thank you. We've just got a few more minutes, 5 minutes of the chat, the final chat. David.
Can I say something? But I think it was Steve who said, how do they do it? It's when you've got to have your own ideas, like primary care or whatever, But you've got to seize the moment. The alliance is not just horizontally, it's also vertically. And every so often, leaders emerge, and you've got to seize the moment. Ireland was quite simple, because I've been involved a bit. They have just realised that what the future is for most healthcare is long-term conditions, chronic disease. And the best way to tackle comorbidity and its complexities is locally and in the community. So it was that idea that drove the change. I don't know why Israel went for that model of universal care integrated. I don't know, because that was the 1990s. But it strikes me that it's seizing the opportunity. So when even though I'm not a Tory, when the Tories introduced their healthcare reforms, many of us jumped on it because it gave a vehicle. You don't have to believe the damn philosophy. Grab the opportunity. And sometimes if you're doing stuff, they appreciate it, even if you haven't done what they wanted to do in the first place. So it's that readiness to jump and to seize opportunities. And most of us wait and are skeptical and miss the damn time. It's that seizing the moment idea. And it's absolutely crucial, because most people, like a politician or a senior manager or whatever, they have other things to do, and if the moment isn't seized, you waste a great opportunity. So
isn't it also the context that if you've experienced great poverty and abuse and rejection, it's very obvious to see why you need socialism. But Julian Tudor Hart, I mean, he set up the most amazing GP, but look at the context. It's a mining village, Glencorrig in South Wales, close to Aberfan and Merthyr Tydfil and some of these well-known, desperately poor places. So it's obvious you come in listening and thinking and helping people to engage, and they're going to engage. You move to a different point in history when that isn't going on, then people accept as normal whatever it is they inherit. So there's more thinking, I think, about how one gets people to appreciate what they've got, not just fight against the problems they've experienced.
That's true, Paul, but it's just that sometimes if you're ready and not too precious about your ideas, when the stars aligned or people aligned is a season moment. A new government might be it, for instance, a financial crisis. That Obama saying never waste a crisis.
Yeah.
It's absolutely right. When people need things most.
So one of the things at least we need to teach is how to do that. And I think one thing, for example, the end of life situation, which can be really incredibly difficult, might be one of the best places to learn about this kind of stuff, precisely because it is so difficult.
But as you say, David, you've got to seize the opportunity and make it palatable as well. I think that's terribly important if we're going to influence upwards as well as downwards. Yeah. And we've talked about Nigel talked about the importance of going upstream and influencing the young people coming in, or the not so young people coming in, the new practitioners coming in as well. It's got to be worked out in different ways, hasn't it? I mean, Paul, it's end of life is one area, and there are other areas that we can look at where the seeds can really take root.
So just at the end. But we talk about relationships. That's a sort of relationship, isn't it? With some of the politicians, you may not even necessarily like them, but if there's an opportunity, maybe have no soul, but grab it when you can seems to be. Like I say, the Tory health reforms gave people like me a great opportunity to do something which they didn't want us to do in the first place. But what the hell, some of the policy ideas seem to be one area. And I just think we're often on the left too sniffy.
Let's hope that whichever government's coming in, they need some ideas from people like us, and we can produce them. And this is what this is all about, isn't it? Getting the ideas out there.
Yes, that's an icebreaker, a new government, for instance, yes. But the ice soon freezes over, is what I say.
Yeah, early days, get in there quick. Yeah.
Hi guys. Sorry, I would just like to say thank you on behalf of the junior for this inspiring talk tonight. I'm a PhD student from Denmark and a GP to be. And even though it's a doctor of a completely different country, we face some very similar issues. Hence why we're working with Imperial College on a proposal for sort of a brighter future for general practice and a more patient-centered care in primary care. But yeah, sadly, already on my second day as a junior doctor, I heard the phrase, and it was the first phrase ever taught to me: keep your back clean, and then you can check if the patient has free airways. And that was sort of my stepping stone to a very sad start in how we lost the patient in focus that was actually in front of me. So it really struck me, David, when you talked about the contracts and the hard outcomes that we now have a focus on instead of the patients in question. So I want to thank you all. I know that Hazel described you as dinosaurs or whatever she used, but I'm very thankful that I get to be a junior and sort of draw from your experience and take this with me. I'm sure it will mean a great deal in my future as a GP and to be the doctor that I want to become. Brilliant.
Thank you, everyone. I think we've reached the witching hour. It's just getting up there, isn't it? Everybody's been brilliant. Thank you. We didn't get to hear from everyone, but I think we've had some very interesting comments, and there's more to come. As I said, this is just the start. It's an exciting place to be.